Hello, my name is Nikisha Sturgill, and this presentation is on the guidelines of hyperlipidemia. Study shows that in the United States, over 100 million adults are diagnosed with elevated low-density lipoprotein cholesterol. Yet, very few are receiving effective treatment to reduce and to control their LDL levels. Study also shows that over 30 million American adults are at risk for atherosclerotic cardiovascular disease caused by an elevated total cholesterol level. Also, adults with hyperlipidemia are more likely to develop cardiovascular disease early in life, resulting in morbid conditions if not treated effectively. Therefore, screening and efficiency with treatment are necessary to promote health and reduce deaths caused by plaque buildup in the arteries. Hyperlipidemia is an elevation of blood lipid levels, cholesterol or triglycerides, within the cell walls. This buildup of lipid levels within the cells reduces the amount of receptors on the surfaces of the cells, blocking the lipids from entering the cell, causing smooth muscle damage and the formation of plaque in the arteries. This formation of plaque in the arteries causes narrowing in the arteries and the blood vessels. Because of the narrowing in the arteries and the blood vessels, the heart has to pump harder to get blood through the body, causing problems and morbid conditions. The normal cholesterol levels are listed. The total cholesterol level should be less than 200 milligrams per deciliter. A low density level should be at least 100, and the high density level should be 40 to 59. Hyperlipidemia does not usually present in a patient until after it's too late to correct. Study shows that abnormal cholesterol levels are usually observed on lipid panels after a patient has already had a cardiovascular event, such as a myocardial infarction and a cerebrovascular accident. Hyperlipidemia is diagnosed by a blood test called a lipid panel. There are several risk factors for hyperlipidemia in patients. There's the coronary artery syndrome, history of a heart attack, chest pain, CVA, TIA, PAD, diabetes, family history, obesity, um, high-fat diets, and African American women. Here you'll see the types of statin therapy. They're high-intensity therapies, they're moderate intensity therapies, and they're low intensity therapies with the statins. The high intensity therapy is used to reduce the LDL 50% or more in patients. The moderate is used to reduce the LDL 30 to less than 50% in patients. And the low intensity is used to reduce the LDL 30% or less in patients. The American College, also called the ACC, and the American Heart Association, the AHA, developed the hyperlipidemia guideline in 2003 and later revised this guideline in 2013. This revised guideline focuses on treatment with statins and is aimed to reduce atherosclerotic diseases in those at every risk level, even those not diagnosed with a CAD. Unlike the previous guideline of 2003, the 2013 guidelines that uses evidence-based treatment with statins as a primary, meaning those before they're diagnosed with a disorder, and a secondary, those that are diagnosed with hyperlipidemia. The guidelines promote appropriate doses of statins to treat patients, and they use the high intensity, the moderate intensity, and the low intensity. With the 10-year risk factor for the ASCVD, there is no specific recommendation. However, those that have atherosclerotic cardiovascular disease It is suggested by this guideline that the high intensity statins are used. And with those that are already diagnosed with diabetes, the moderate to the high intensity statin therapy should be used. However, those with chronic kidney disease, stage 3 or worse, there are no specific recommendations using this guideline. And those patients with a high LDL, 190 or greater, this guideline suggests using moderate intensity statins. The ACC and the AHA guidelines were generated by an expert panel. The guidelines provide consistency with care. The purpose of the guideline is to reduce atherosclerotic cardiovascular risk by efficient treatment of blood cholesterol. This guideline differs from the old guideline in that it does not use fixed statin doses. The statins may prevent clotting events by reducing cholesterol and arterial plaque in the blood vessels. This guideline is very important because vascular diseases are important causes of death and disabilities, and there is evidence that statins reduce mortality, heart attacks, and strokes. In the 2013 revised guidelines, it focuses on controlling the LDL and modifying treatment until the LDL is less than 100. Instead, it's less than 70 instead of 100 for patients with chronic heart disease. The 2003 guideline was more focused on getting the level down to less than 100 instead of 70. Also, the guidelines suggest primary treatment for those at risk and not just those diagnosed with CAD. The key action statements and the body of evidence are listed here. The ACC and the AHA dose statins treatment by using a randomized controlled trial that was developed and reviewed by an expert panel. Unlike the old guideline in 2003, it did not use a randomized controlled trial. It was not evidence-based. This guideline was also endorsed by the American Academy of Family Physicians. So there are many professional organizations that support the use of this guideline. The guideline does increase the amount of patients that could potentially be prescribed on statins. For instance, those that are at risk of having a heart disorder could be prescribed a statin, and also those that are diagnosed with a cardiovascular heart disease will be diagnosed with a statin. So it does increase the potential for those to be prescribed with a statin. This guideline uses evidence to prove that maximum tolerated statins can reduce the bad cholesterol, which is the LDL. The body of evidence goes as such. Healthy heart lifestyle habits should be taught and encouraged along with statin therapy. Statins can be effective, but may not completely eliminate the patient's risk for heart disease if the lifestyle is not healthy for the heart. Also, before starting a statin, the physician needs to discuss with the patient the preference, the lifestyle, risk, and potential for adverse effects that should be discussed. For instance, it is said that some statins induce diabetes. Therefore, if the patient is already diagnosed with diabetes, the modification in treatment and deciding which statin is appropriate for this patient should be decided. Statins should be used as a primary prevention to reduce the risk of heart diseases. So primary meaning before the patient is even diagnosed with a disorder. Primary preventions are for those that are at risk for this disorder, such as those with the obesity and African Americans, those that are not healthy, those that drink alcohol, etc. Also, statins should be used as a secondary prevention to reduce the risk of deaths in patients already diagnosed with atherosclerotic disease. Now here, this was my clinical practice patient. I had a 65-year-old woman, African American, with a history of dyslipidemia, CAD, hypertension, obesity, depression, MI with a stent placement, and she was in for a routine annual examination. Her vital signs were BP 144/65, her heart rate was a 77, respiration 18, and her oral temp was a 97.8. Her BMI was a 43.1. Her most recent fasting LDL was discussed with her, and it was a 173, and her HDL was a 35. These labs were taken 6 months prior to this visit. She did not have any complaints on this visit. Nutritional counseling was given to her because of her BMI level. Discussion on weight management, activity, and exercise was also discussed. Because of her history of depression, her mood was assessed and discussed, and she denied any depression occurrences. The patient took losartan 80 milligrams daily, Brilinta, Lexapro, and Plavix. She had risk factors for hyperlipidemia, and she was already diagnosed. Well, she had risk factors for coronary artery disease and cardiovascular diseases. She was obesity. She had a history of heart disease, hypertension, history of lipidemia, and a history of a heart attack. Now, this patient was prescribed a moderate intensity statin, which was lovastatin. It was moderate. However, there's a chance that atorvastatin probably was not tolerated because this patient should have been, according to the guideline, diagnosed with a high intensity statin, such as atorvastatin, 80 milligrams. But instead, she was prescribed, I said diagnosed, she was prescribed lovastatin at a very high dose, 80 milligrams. This patient has several risk factors for another ASCVD. Her lipids should be checked every 3 to 12 months for efficiency of treatment. So she probably should, yeah, she came in around the right time. She came in and this was her 6 months checkup. So she was in 6 months later. Her lifestyle modification should be encouraged, and it was done, such as nutritional counseling, weight management, and exercises was discussed with the patient. The type of diet she was eating. It was discussed that the holiday came around and she had just went overboard with celebrating the holiday. But she said she was getting back on track. We assessed the patient for compliance with her medications because even if she wasn't eating appropriate, even if she was eating appropriately, if she was not taking her medication, she was still at risk for an abnormal level. What should be done according to guideline is considering adding a non-statin therapy to this patient, and such as I cannot pronounce this drug, please excuse me, but this medication should be added along with the statin that she is taking at 10 milligrams by mouth daily. And this concludes my presentation on the guidelines of hyperlipidemia. Thank you.